Hello again and welcome. We're looking at level 3 health and social care, unit 6, the stroke unit, stroke or CVA. And we're still in week 3 and we're looking at the second part of the week, part 6, in our set of slides. And we're looking at acute and long-term care standards. Okay, so the objective that we're going to look at is criteria 3.1. Describe the acute and long-term care post CVA. So you need to really break up your thinking into the acute period, which is pretty much the first 2 or 3 days. So try and stay focused on that. And long-term care. So what do we do after that? So over the next few days, weeks, months. Okay. There are over 1.2 million stroke survivors, and out of that, 2/3 of them leave hospital with a disability. So all of those people will need some sort of a longer term care. The average age for people having a stroke is decreasing. It used to be in later life very often, but now it's much more frequent between the age of 40 and 69. We can talk about how this has come around, and you could do some research on that if you want. Generally, the answer is very much is obviously stress very often, and all the other health inequalities that we've talked about elsewhere. Survival rates have improved, but really what's important is how quickly we treat people in that first 2 or 3 days, first couple of hours mostly, and then the first 2 or 3 days getting all the interventions done, and then a different type of treatment later on, the long-term treatment, which is a much slower, steadier piece of work. So in the first from the first moment someone arrives to the end of the first 3 days, it's a bit frantic. There's a lot of rushing around and a lot of things that have to be put into place, scans, blood tests, ultrasounds, those sorts of things. Stuff that we've already just talked about in the diagnostic area. So when you're writing about the acute phase, most of the work you're writing about will be that diagnostic work that we talked about in our last session. Okay, so you're going to break the answer to this question up into 2. The acute phase with all the diagnostic stuff. Make sure you've written enough on that, and then write a summary, because I'm going to tell you quite a lot really, but you're going to have to think of a way of summarizing it within your word count. What else do we do in the longer, slower processes? Okay. And to do that, I'm going to talk you through what we have is the right care stroke pathway that was developed with NICE guidance. It was developed by NHS England, and a stroke working party as well. So, and the Stroke Association. Lots and lots of people who are very involved in stroke issues have developed these care pathways and standards that we're going to look at. Okay, so if I talk to you about the quality standards, I'm going to tell you what the standards are, and then I'm going to tell you what the rationale for is. Why do we do these things? So you'll have a gold standard to write about. Okay. Now I can't guarantee to you that every single hospital follows these standards. They are supposed to, but the way of the world is that things don't always quite happen like that. But they are supposed to follow these standards so that they can come under criticism if they don't. But for your answer, you should be writing about what is expected, because unless you're doing a specific piece of research into an individual hospital, you can't really know exactly what they've done. Okay. So let's talk about the standards and the rationale for them. So what I would suggest you do is you summarize the standards and summarize the rationales. Okay. So the quality standard is expected to contribute to improvements in the following outcomes. So reduce mortality, reduce long-term disability, improve the patient's experience of having a stroke, if one can do that, but do the best you can, and improve the experience of carers, both professional and non-professional, so family and friends, as well as professional carers who will go on to look after people who've had a stroke. So by meeting all these standards and giving someone a better service, hopefully the outcomes will be better as well. So the first quality statement really focuses on that acute time. So this is your time to write about the acute area. And the idea is that the things that should happen within the first 4 hours of arrival. Okay. So specialist acute stroke units are definitely associated with improved patient safety. So one of the things that should happen within that first 4 hours, you may well have your CT scan, all those very quick things that have to be done in A&E. And then the most important thing is to get someone within 4 hours into a specialist stroke unit. Okay, move someone to a specialist stroke unit. And within that specialist stroke unit, there are people with more very, very particular skills in working regularly with people with stroke. So they'll pick things up quicker, they'll see things differently, and they've got a wider experience. Okay, so hopefully mistakes don't happen. Okay, we're going to talk a little bit more about specialist stroke units next week in our last week's couple of sessions. So I'll go on about them in a bit more detail then. But one of the things is, so the first thing is in your acute phase is to do all the stuff that we talked about in our last set of slides. That needs to happen within the first hour to 24 hours really. And then within 4 hours of arrival, they should also be moved to the stroke unit. Okay. Okay, quality statement 2 is the intensity of stroke rehab. And what they did was they identified how much specific rehabilitation work should be done after people have been stabilized. So now we're looking at the fact that someone's stable. We're not looking at the fact that someone's, dangerously ill or unconscious. We're looking at the fact that they're in the stroke unit, but now they're a bit more stable. Okay. And they have to have at least 45 minutes of whatever therapy has been identified. So, if you've got right-sided paralysis, there'll be a lot of physical therapy going on. If you've got swallowing issues, there'll be therapy there. Various things like that. Gripping issues, there'll be therapy related to that. So we'll start. This is when we're starting to address the symptoms once that emergency period of time is over. 45 minutes of whatever therapy. So if you need 2 or 3 therapies, you'll have 45 minutes of each of them. Okay, physio, speech and language, some other psychology it could be. So you could be pretty busy during the day and exhausted as well. And they should have that for at least five days every week. So they have a couple of days off because they need a little bit of time for recovery as well. Okay, so but then no less than 5 days should you, because otherwise the therapies, you'll go forward and then you'll go back if you have too much time off. Okay, and the reason for this is really high intensity rehabilitation can improve quality of life, and it can enable people to recover a lot quicker. Okay, and it really depends on their health and abilities before. You can't always predict how well people will recover, and it also depends how severe their stroke is. But we do know that without that very regular therapy, with the best will in the world, even the healthiest people will struggle to recover if they're not having at least five sessions a week. Okay. So the types of therapy, as I've described, a lot of it is physical therapy. And that's about, muscles, getting the paralyzed area working. Maybe if you've got one arm, using something else for a while until it recovers, but sort of slowly exercising it. We'll talk about that more again in our next set of sessions. Occupational therapy, which is eating, drinking, swallowing, dressing, bathing, cooking, using the toilet. So about your own personal living skills. There might be some adaptations to do for a while, or there might be long-term adaptations, but either way, those therapies need to be happening. So, the walking practice, um, helping someone in the shower, helping them sort of with, especially if they've got a paralyzed side, finding a way for them to stand up when they can't, using a walking frame for a while. I mean, they actually have to learn to use those too, because they're not always as obvious as they think. Okay, speech and language, as I said, swallowing for some people, but also very, very important for those who have affected speech, which is one of the things that really frustrates people the most, is when their speech is affected. Speech and language therapists need to get onto that very, very quickly, and they have all sorts of different types of exercises to do. Access to a clinical psychologist. So adults who have had stroke should have access to a clinical psychologist. Hopefully, if they're in a stroke unit, there's one on the team. If not, they have to have sessions from outside. Psychological difficulties, issues with cognition. We know about problems with memory. We know information processing can be affected. We also know there are emotional issues on the side that a psychologist can work with as well, such as low mood and anxiety, depression, those sorts of things. So it's very, very important that the stroke rehab team has a clinical psychologist, or at least access to so many hours of one from somewhere else. Adults who've had a stroke should actually be offered early supported discharge. So it's about getting people out of hospital quick, really, because hospital, well, most people feel that hospital is a negative place to be. People tend to have a much more positive outlook when they're out of hospital. So making sure that there's a good community team in place so that their rehab can go on at home. It's a lot easier practicing your living skills in your own house, because then you could start adjusting to, how do I get around my own home? How do I get upstairs to my bedroom, in and out? Do I need some developments in my bathroom to make it accessible? Will I need to change to a walk-in shower? Those sorts of things. Early supported discharge is something that people should be working to really from the day someone arrives. Okay. And for some people, it might not be suitable. They may have to spend a longer time in hospital, or they may in time decide not to come back to their home, but maybe to come into a care home so that people like yourselves can care for them. But really, you need to be working on those areas, and at least you need to be trying people at home and finding out what the problems are. Early supported discharge gives the occupational therapist a chance to get into the house and see what they may need to change, because in the UK there are grants that can be applied for that can get developments done. So like widening of rooms, dropping stairs, putting in stair lifts, putting in ramps if someone's going to be using a wheelchair, and that. Lots of things to do really, to help people live at home. Adults who had a stroke are offered active management to return to work if they wish to do so. Obviously, it really depends on the level of someone's disability, but the idea is not to rule out the idea, but to be positive. And this is really, really important with younger people, particularly who've had stroke. If someone's over 60, they might take that time and decide, okay, maybe I'm going to retire now. But if you're 40, there's a lot more tied up in earning a living. So work can really be important for someone's personal identity, for their emotional well-being, and obviously it helps financially as well and improve their quality of life. So being able to return to work is a real sign to the individual that their rehab is actually happening and progressing. So it's about working with people to do that. Now, it won't work for everybody, and for some people, depending on what job they did, they and if they retain some disabilities, they may not be able to work again. You know, if you work as a fireman, and you know you're actually your stroke's been quite severe and you're now in a wheelchair, that's going to be tough. But that doesn't mean to say that they can't maybe do something else. So part of the occupational therapist work is to bring in very specialist organisations to help with what else can somebody do if they want to work. As I said, particularly the younger stroke victims. Regular review of the rehabilitation goals. So everybody who's got a rehabilitation will have a very detailed care plan explaining what that is and telling friends, family, and carers what their role in it as well. So hopefully they'll be involved in the discussion of the plan. And these goals have to be reviewed at regular intervals. What we're looking at with stroke is to keep sort of finding changes, keep seeing improvements. So we don't have really, really long reviews, like a year at a time, because you're not picking up on the changes and the movement of change there. So the idea is to have some goals might be every 2 weeks or every week or at least monthly, maybe not more than that. So regularly reviewing. So when somebody arrives in A&E in the first place, within the first 5 days of them having, once they've moved to their stroke unit, that care plan should be set and the first sets of reviews should start to be happening. So if it's someone's after a period of time, if things can stretch out, and goals can be 6 weeks, 3 months, 6 months, and annually. But if someone's suffering from a stroke, they should at least be reviewed every year after a period of time. Once they feel they've got to an area, or you know they've managing their disability as well as they can, they should still be reviewed annually, because what you don't want to do is for them to go backwards. Okay, so never less than annually after a period of time. So that's all there is about that. For some further reading, just reflect on the standards that I've written up for you, and you can do a little bit of research and find how well they've been achieved. So I've put a document in extra reading, which is a review of those standards, and you can see where things maybe have gone well with some of those standards and where things haven't gone so well. Okay, so you can get an idea about that. You might want to write about that as well. But it would just, give you some food for thought for the standards. I mean, are they realistic? Are they not realistic? And what's the problem with them? Okay, so before you move on to next week's work, take some time, read that document, and maybe make yourself some notes about where the standards haven't done as well. Okay, that's it for this session, and I will see you again for next week's sessions. Goodbye.